Let's go ahead and learn about two different diseases, peptic ulcer disease and GERD, for your Medsurg or adult health nursing course, and of course for the NCLEX. Now, first of all, these are two separate diseases, peptic ulcer disease and gastroesophageal reflux disease. However, in most nursing programs, these are taught together to help you compare and contrast the two because they do have a lot of similarities, such as the basics of the patho and the treatment are very similar, the signs and symptoms overlap, so it helps to compare and contrast the two. Let's start with pathophysiology, but let's back up 1 second. In our stomach, we have something called the gastric acid or gastric juices. These gastric fluids essentially neutralize or sterilize everything that we eat that comes into our body. Think about it. You, as a nurse, when you put something in a patient like a Foley or an IV catheter, those have to be sterile. However, in the case of food, what we eat, that doesn't have to be sterile. And that's because the gastric acids sort of neutralize or sterilize the food that we eat so that it can't harm us. Now, this gastric acid is very powerful, very strong, very toxic, and it can damage our actual body, our tissue, our blood vessels, etc. So, to protect ourselves from that, the stomach has something called the gastric mucosa. This stomach lining is very protective and it keeps this gastric acid from touching or hurting any of the underlying tissue, any of the underlying organs, blood vessels, anything else. It keeps it sort of trapped in the gastric area so that this gastric acid doesn't hurt anything else in our body. Because if it got through that gastric mucosa, it would be a problem. That's exactly what peptic ulcer disease is. It is a hole in the lining of the stomach or the duodenum. We have two different types of peptic ulcer disease. There's duodenal ulcer and there's gastric ulcer. Gastric is in the stomach, duodenal is in the duodenum. But in either one of these cases, it's a hole, it's an ulcer in that protective lining. And now this toxic fluid can access or touch or hurt, however you want to explain it, but it's able to get through the gastric lining because of this ulcer, because of this hole. And now it's able to hurt the underlying tissue, especially blood vessels. It can eat into blood vessels and that can cause a GI bleed, which we're going to talk about in a few minutes. Now, GERD is going to be, again, the same problem that this gastric acid is where it doesn't belong. But in the case of GERD, we have something called the LES, the lower esophageal sphincter. The lower esophageal sphincter sits between the esophagus and the stomach, and it's a one-way valve, and it keeps food going from the esophagus into the stomach, and specifically, it keeps the gastric acid or food soaked in the gastric acid from coming back up into the esophagus. When the LES, the lower esophageal sphincter, fails, now food is able to come up into the esophagus, or specifically food that's soaked in this juice, or the juice itself is able to come back up into the esophagus, which is very toxic and harmful to the tissue of the esophagus. So they both share a similar pathophysiology. They both have a problem with this gastric acid. Peptic ulcer disease is because of a whole gastroesophageal reflux disease is because it comes up into the esophagus. Now let's look at signs and symptoms. For peptic ulcer disease, you're going to have abdominal pain, you're going to have dyspepsia, which is known as indigestion or heartburn. And so some nursing schools are going to teach you about duodenal versus gastric ulcer, and specifically that duodenal ulcers feel better when a patient eats a meal and a gastric ulcer feels worse when a patient eats a meal. I put this here because some nursing schools teach it and I've seen it on some test banks. I don't think the NCLEX would test on it because it's not that reliable. Moving on to GERD. GERD, the signs and symptoms is dyspepsia. Again, that's heartburn. That's going to be the classic presentation of GERD. Also a cough. One of the top 5 reasons of why a patient would develop a chronic cough is due to GERD. Let's look at the diagnostics. For peptic ulcer disease, the official way to diagnose it is with an upper endoscopy known as an EGD. Now, there is another test we're going to order for anyone that we suspect a peptic ulcer disease, and that's to figure out what is causing the peptic ulcer. Specifically, is it a bacterial pathogen called H. pylori? Helicobacter pylori is one of the top 2 causes of peptic ulcer disease, and if a patient has a peptic ulcer disease, this hole in their stomach lining, and it's because of H. pylori, we have to give an antibiotic to kill off that bacterial pathogen. If it's from another cause other than H. pylori, we don't need to give antibiotics. So we're going to do this breath test to see if the patient has H. pylori peptic ulcer disease or some other cause peptic ulcer disease. Now, for GERD, there's no official test to diagnose GERD. I don't have GERD, just the cough. There's no official test to diagnose GERD. However, it's just based on the patient's presentation, the history, and the physical exam. Now let's talk about the nursing assessment. For peptic ulcer disease, the big thing we're going to look at is to see if they have any of the risk factors. So the risk factors of peptic ulcer disease are going to be the top two causes of what causes a peptic ulcer. One is going to be H. pylori. We already said that's a bacterial pathogen, Helicobacter pylori, or NSAIDs. NSAIDs, if you remember from your pharmacology class, are inhibitors of COX-1 and COX-2, cyclooxygenase 1 and cyclooxygenase 2. If you remember really well from pharmacology, you might remember that COX-1 is responsible for building up the stomach lining. NSAIDs block that, so they weaken the stomach lining and they cause ulcer. H. pylori and NSAIDs are the top two causes of ulcers. There are other causes, smoking, stress, etc., but the top two, certainly for test purposes on a Medsurg test or the NCLEX, is going to be H. pylori and NSAIDs. GERD is going to be a multitude of factors of what causes it. There's some genetic component, certainly lifestyle part of it. Obesity can cause it. Smoking can cause it. Caffeine has been shown to cause it. There's a number of additional ones as well. I don't know how much you'd be testing on that in the Medsurg course at the RN level. Now let's talk about nursing priorities. For peptic ulcer disease, by far the most tested on thing is to watch for GI bleeding. Peptic ulcer disease, the number one complication is that it can cause a GI bleed. That means asking the patient about blood in the stool, about black tarry stools. You might want to do a FOBT, a fecal occult blood test, to check for that GI bleed, because that's going to be your number one priority. In GERD, that priority is going to be the clinical education, the client education about what they can do to make this better, and we'll get to that in just a few minutes. Let's talk about treatment. For GERD, we're going to focus on lifestyle modifications that I'll get to in a few minutes with the client education box. For peptic ulcer disease, it's going to be pharmacotherapy. But in both of these cases, we may get to medications. Peptic ulcer disease, we're going to go straight to medications, but with GERD, we may also put the patient on a medication. So what medications do we start with? Well, we have two basic first-line options, which are PPIs and H2RAs. PPIs are proton pump inhibitors. Proton pumps pump out this acid into the stomach, so by inhibiting it, I lower the acidity of the gastric juice. The second drug class is H2RAs, histamine 2 receptor antagonists. Histamine 2 receptors also pump out gastric acid, though not as much as the proton pumps, into the stomach. So again, by antagonizing that or blocking that, I reduce the amount of acid that goes into the stomach. I reduce the acidity of these gastric fluids, and since they're not as toxic, they're not as acidic, makes the environment more conducive to the ulcer healing or to the esophageal tissue healing, whether we're talking about peptic ulcer disease or GERD. So either one of these might start off with a PPI or an H2RA. Generally, we go with a PPI. It's more potent, it's more powerful. We prefer to just go through that. If there's a question about a patient ending up on it long term, such as with GERD, we would rather, if a patient's going to take it long term, we would rather the H2RA. Let's talk about that for a minute. We do not want patients on a PPI long term, meaning more than 4 to 8 weeks. If the patient's on a PPI for, let's say, 6 months or 6 years, odds are they're not coming off of that drug. They're going to be dependent on it for the rest of their life, because as soon as they stop taking it, their indigestion is going to come right back. If you think about it, that makes sense. The PPIs keep the acidity level in the stomach at a more calm, more mellow level. And if we stop taking it, now it goes back to this vicious toxic gastric acid. The stomach won't tolerate that well. That's why patients usually have to stick with this. Now, once the patient, so for a peptic ulcer disease, they're going to take it for 4 to 8 weeks to allow the peptic ulcer to heal, and then they're done. If the patient is taking it for GERD, they may be on it more long term. Now, in either case, if a patient is taking a PPI, just a pharmacology tip, and this is commonly tested on, the patients must supplement with calcium and vitamin D if they're taking it long term. Otherwise, this medication, PPIs, will increase their risk of osteoporosis. Another medication that's available for patients with GERD or that indigestion is going to be antacids. Antacids such as Tums, which is calcium carbonate, is another part of the treatment plan for GERD. And the big thing to know about antacids for testing purposes is the fact that it can't be taken with any other medication. If a patient has taken an antacid or is going to take an antacid, all other medications have to be given an hour prior or 2 hours after administration of an antacid. Some textbooks I've seen even go 2 hours before and 4 hours after. Now, if the peptic ulcer disease is caused by H. pylori, by that bacterial infection, then we also need to give an antibiotic. The antibiotics commonly given are clarithromycin with amoxicillin, possibly also with metronidazole. All of this will be in addition to a PPI. So one last time, lifestyle modifications definitely for GERD, more important there than it is in peptic ulcer disease. Pharmacotherapy, short-term treatment, we're going to go for a PPI. If it's going to be long-term, we prefer the H2RA. Antacids is the quick relief option. Let's go to client education. For peptic ulcer disease, if it's caused by NSAIDs, we definitely want them to avoid the NSAIDs going forward. We also want them to avoid smoking going forward because that can make it worse. For GERD, we have a bunch of little things that we want to educate patients on, and this is all really good testable material for Medsurg, so make sure you got this. We want the patient to lose weight because we already said that obesity is one of the causative factors. We want to elevate their head of the bed, especially after meals. We don't want them lying flat. We want them to avoid specific trigger foods, things such as chocolate, caffeine, alcohol. Every patient has their own. These are the commonly tested on ones. We want them to avoid those. We want them to stay upright after meals. We want them to not eat right before bed, and we want them to eat smaller meals. All of those are things that can help with GERD. Finally, the complications, peptic ulcer disease, we already mentioned the top complication is going to be a GI bleed. And finally, for GERD, the top complication is going to be Barrett esophagus. Hopefully this covered everything you need to know for your Medsurg or adult health course. If you're getting ready for the NCLEX, good luck, and I'll see you in the next video.